Hi, everyone, and welcome to another episode of the Cases podcast. Today we're talking about sleep. My name's Jim Lee. I'm a GP in Sheffield and work as a cases peer reviewer for respiratory. And I'm delighted today to be joined by Ram Iyer. Ram, could you just introduce yourself and tell us a little bit about yourself?
Yes, thank you, Jim. Thanks for the invite. Delighted to be here. So I'm Ram Iyer. I'm a respiratory and sleep physician. I lead the sleep service in Sheffield. So I deal with respiratory sleep disorders, but I also do neurology sleep, which is again at the Hallamshire Hospital, where I run a neurology clinic every fortnight. In addition, I have other sleep roles on the national stage. I sit on the British Thoracic Society Committee for the Specialist Advisory Group for Sleep, and I'm the Royal Society of Medicine Sleep President. I do a lot of medical legal work for sleep, so quite heavily invested in sleep, I'm afraid.
No, that's great. Thank you very much. So maybe we could just start with a fairly broad question. Why is sleep so important?
Yes, I mean, sleep is a vital function, much like eating and exercising, uh, good diet, good nutrition, good mental health well-being. And we see that because people who don't sleep very well end up with symptoms that affect the quality of life, and in the long term cause both physical and mental health consequences. But importantly, I think from a GP perspective, we also see people who have problems with sleep as a systemic manifestation of other illnesses. I think much like a common road that leads to a lot of other diseases, sleep symptoms can be a hallmark of other medical conditions.
Yeah. Okay. And what are the manifestations of kind of sleep disorders that we're likely to be seeing?
Yeah, the commonest sleep disorder or complaint you're going to see is poor sleep, isn't it? And that's a very poorly defined, subjective complaint that requires further clarification from the patient, because a poor sleep can mean different things for different people. It could mean that sleep is unrefreshing. Or it could mean that people find that their nighttime sleep is very disturbed. It could mean that their partners have complained of various sleep complaints during the night, subjectively, or it could also mean that they are so sleepy during the day that they can barely stay awake. I mean, I would probably keep this discussion for the purposes of this talk. I would keep them within the spectrum of those sorts of complaints.
Yeah. Okay. Thank you. So if we're in our kind of 10-minute GP appointment, what are the kind of most important things that we should be trying to kind of elicit and identify in terms of our assessment of sleep problems?
Yeah, and that's entirely reasonable question given your time constraints, and given all of the things that you might have to cover with the patient in a consultation. The first thing to say is if you find that the patient is constantly falling asleep in front of you, that is completely abnormal. And that is not normal under any circumstances. That immediately warrants medical attention because that indicates a serious problem with the sleep. Now, that does happen. It happens to me in my clinic, and it'll happen to you in your clinic, where there is a description of uncontrollable sleepiness to the point that they are falling asleep all the time. And I guess the second barometer of severity in my book is, as I said, sleepiness in situations where you're expected to be awake. So sleepiness in the middle of conversations, sleepiness while driving, which I'm sure you'll come on to later, and sleepiness in any situation that actually demands alertness, especially during the day. So all of those are warning signs. Uh, then there are the less sort of obvious symptoms. So somebody might come to you with a symptom of fatigue or tiredness, and it's then the GP's job to tease out what is really fatigue from what is really sleepiness, because a lot of patients will use that interchangeably. So as an example, people with chronic fatigue syndrome or people with autoimmune conditions will frequently describe fatigue during the day. And it's important to tease out whether this is general fatigue and lack of energy, or whether this is actually what they describe as being sleepy and being liable to falling asleep during the day. So once you've established that this is, it is actually a sleep-related problem, and this is sleepiness they're describing, the next thing I would want to do in a brief sort of 2-minute consultation would be to try and, well, risk stratify them. What I mean by that is how much of a danger are they to themselves and the public? So that means talking about driving, talking about whether they're able to fulfill their duties if they are in a job. And the second risk stratification is more along the lines of, well, what is their cardiovascular risk? So in people with suspected sleep apnea, what we would really like to know from the GP is this person hypertensive? Is this person overweight? Have they got other symptoms or other risks for cardiovascular disease like high cholesterol, diabetes, or ischemic heart disease or cardiac arrhythmias? So yeah, it's a bit of, once I've identified a problem, to work out whether it is sleep related, how severe it is, and what is the risk stratification.
Okay. Are there any particular, other than kind of blood pressure, are there any other kind of things on kind of physical examination that we'd be wanting to look for?
Yeah, the big thing is to work out if they are actually falling asleep in front of you or nodding off. That's useful. I think it's always useful to ask the partner, if a partner is accompanying them, how they are during the day, because quite frequently I find that people with severe sleep apnea sometimes don't always identify daytime symptoms unless the partner then points it out to them. And it's very useful for me to have the partner to say, well, no, that's not correct. He's falling asleep all the time while he's chatting with me. He just doesn't realize it. So getting a corroborative history, if you have the chance, is really important. In terms of physical examination, it's one of those rare um, medical specialties where it's perhaps not as important as it is in other areas. Certainly, you want to look for signs of heart failure, and we see that with uncontrolled severe sleep apnea. Quite often, the first manifestation could be right heart failure. So, leg edema, raised GVP as a baseline. And then a quick cursory sort of ear, nose, and throat examination is always helpful. How big is their tongue? If you're using the Malampati score to evaluate how their throat is, that gives us a good idea of what the likelihood of sleep apnea is going to be if the throat is very narrow. Enlarged tonsils, really important when we are assessing management of sleep apnea. And then finally, nasal symptoms like nasal polyps that might tell me that these people are unlikely to benefit from a nasal mask, for example, and they're more likely to require full face mask therapy.
Yeah, great, thank you. And are there any kind of broad rules we could be thinking about in terms of which kind of cases we should be managing in primary care versus those that we should be referring on for secondary care review?
Yeah, I guess if you look at the spectrum of sleep disorders, and I'll probably the best way to address this is to look at the individual conditions that you're likely to see. Sleep apnea assessment, I think, is at the moment at least best done in secondary care, because these patients are going to need a baseline sleep study. And although there may well be a plan to organize that in primary care itself, which I think would be a fantastic thing. For now, if they need a sleep study, the best thing to do is to refer them into the respiratory sleep service. And we've got a fast track pathway where they don't really get seen by a sleep consultant initially. They go on to have a sleep study. And if all they have is sleep apnea, is uncomplicated, they get treated for it. And sometimes they don't even come to my sleep clinic. They get dealt with by the physiology team and who will follow them up. So that is a very good outcome for them, because it is a quickest pathway to diagnosing and treating the condition. If it's more complicated sleep apnea, then normally the physiologist will flag that up and will refer that to me. So in general, for suspected sleep apnea, it's perfectly acceptable to simply refer them on to secondary care and say, please arrange a sleep study. And we generally then tend to do the rest. For insomnia is complex. It's very common. You can argue more common than sleep apnea. The degree to which people seek attention, I think, varies. Some people come to you primarily for an insomnia-related complaint. and others might come to you for other reasons, and you might find that they also have severe symptoms of insomnia. Currently, we don't have insomnia treatment embedded into our service specifications in Sheffield. And this is something that we are discussing and hoping to resolve, because what is really needed for insomnia is an assessment and access to cognitive behavioral therapy for insomnia, which is probably the most effective treatment for insomnia, aside from all of the drugs that we provide. Now, some ICBs have access to digital CBTI, so applications like Sleep Station or Sleepio, which is a paid service, which I think will do a good initial job of providing access to CBTI for a lot of these patients. And other services have a two-tiered system where they have digital CBTI as well as access to a sleep psychologist, or actually an insomnia sleep service per se, where they can be assessed appropriately, and they can be signposted to different treatment options. That would be the gold standard for me. For the moment, though, I guess insomnia doesn't, at least in South Yorkshire, there isn't really a place for them to go to. So there are other sleep apps that can offer some sort of abbreviated CBT therapy, which are free. So Sleepful is one that GPs can simply ask the patient to download, and that has a basic set of CBTI principles that the patient can access. There is this concept of abbreviated CBTI, which allows any practitioner to sort of put forward the principles of managing insomnia to patients within 10 minutes. So I don't know how much detail you want me to go into this, but obviously it has a sleep hygiene component, which probably is relevant for any sleep condition that you see. So sleep hygiene, good principles of good sleep habits, really. So good principles of sleeping, which is regular sleep times, regular wake times, as much as possible. All of the stuff about electronics being kept out of the bedroom, and the last hour leading to sleep being free of electronic time and spent sort of winding down for the day, keeping the bedroom dark, keeping the bedroom cool, avoiding caffeine intake after 2 p.m., minimizing alcohol intake or nicotine intake. So all of the common sense advice that you are so used to providing, I think, have to be extra emphasized for people with sleep issues. So that's that sort of insomnia and sleep apnea. There may be other conditions that you will come across, like parasomnias, people who are sleepwalking or acting out their dreams, for example. Now, the same principles of good sleep hygiene will apply to those people as well. And where the parasomnia might not always be cured, it will at least be alleviated, or will not be exacerbated by adopting principles of good sleep hygiene. So those sleep hygiene principles, I think, are basic. You can pretty much roll them out to any sleep patient that you see. But I would say that if parasomnias are severe, i.e. people are complaining that they are being woken up daily or frequently on a weekly basis because they're sleepwalking or sleep talking, or there are episodes of sleep violence, then I suspect those patients will need to be sent to a sleep center for further assessment. And I guess for parasomnias, I guess the first port of call would be a neurology sleep service, where they can then have a consultation, and then a sleep study as appropriate.
Great. That was one thing I was going to ask about. Was obviously we've got the neurology sleep clinic in Sheffield, but also the sleep clinic kind of that runs under your care with respiratory. Are there any kind of easy distinctions you can give us between which kind of people we should be sending to the neurology clinic and which should be coming to you?
Yeah, that's a really important question, because I still think that people are being sent to the wrong clinics, because GPs don't simply always understand what is provided by each service. So any sleep apnea related problems, or problems related to breathing and sleep, so suspected hypoventilation, central sleep apnea, obstructive sleep apnea, snoring, and maybe sleep apnea, all of that need to go to the respiratory sleep service for a baseline sleep study. anything that is neurology related, like narcolepsy, nighttime seizures, parasomnias, ideally are directed towards the neurology sleep service. Now, if I'm very happy to offer myself up as as a port of call. If there is a confusion as to where the sleep a patient needs to go to, I'm very happy for the GPs to contact me. Or because I'm in this unique position of offering both clinics, neurology and respiratory clinics, they could simply refer it to me and I will direct it appropriately.
Okay, great. Is there a particular how just thinking from the practical point of view, using ERS, is there a particular way that should be kind of directed to you on ERS?
If they mark it to my attention rather than because normally what happens is as you know, they go through there's a couple of my colleagues who do the advice and guidance section, so they will probably handle a lot of these referrals. But if my name is simply there as a for my attention to action, it'll come straight through to me.
Right. Okay. So just through the kind of respiratory sleep service to your name.
Yes, please. If there is a confusion as to where the patient has to go to, but if there's a very clear distinction of, well, this is non-respiratory sleep because this person could have a neurological problem or a parasomnia, that can simply go to neurology directly.
Yeah. Great. Okay. Thank you. So getting back to something we kind of touched on earlier in relation to sleep apnea, I think one thing that can be quite difficult for us in general practice is the implications of sleepiness on driving. Obviously can be quite a tricky conversation to have with patients. Can you just give us any guidance about who we should be advising about driving in relation to sleep problems and what we should be saying to them?
Yeah, again, really important question, and one that many of my colleagues in the secondary care sector get wrong, let alone GPs. So the DVLA obviously have guidance for various sleep conditions, including sleep apnea, narcolepsy, and unexplained sleepiness. To make it very simple, the best advice to give is the one that makes the most sense. So if patients are describing sleepiness, daytime sleepiness, sleepiness while driving, or they've described a near accident or a near miss because of sleepiness, they should not be driving. And that advice should be very clear in the consultation. This person is sleepy, they should not be driving. And whilst giving them advice, if the sleepiness is not there all the time, but can sometimes be a problem on some days when they drive, they should not be driving on those days. The responsibility of not driving and assessing the degree of sleepiness rests with the patient, not with the GP, not with me. It rests with the patient. That is the responsibility. I guess the only time where you would see fit, or I would see fit, to actually actively intervene and write to the DVLA is a situation where there is a recognition that the patient is continuing to drive despite strong advice from the medical practitioner not to drive, and that in the eyes of the medical professional, they are putting themselves or their family or other members of the public at risk. That's the only time that you would probably write to the DVLA and say this person is driving when they should not be driving. But I maybe had that once or twice in the last 15 years as a sleep consultant. So it's very rare. I leave it to I'm very clear to them that it is your responsibility not to drive. And if you're sleepy, you should not be driving. Now, with respect to sleep apnea, if there is a diagnosis of suspected sleep apnea, then they should not be driving until that diagnosis has been made, especially if their Epworth score is more than 10, i.e., they are describing daytime sleepiness. And then once a diagnosis has been made, that responsibility of advising them rests on the sleep unit, either on my sleep physiologist or myself. And we have a standard protocol for this.
Okay.
Now, if people have been diagnosed with sleep apnea, but are not sleepy, i.e., they have OSA but do not have OSA syndrome, then there is no driving implication. As far as the DVLA is concerned, even if they are not treated for whatever reason, or they are sort of intolerant of treatment because they have not described daytime sleepiness from the beginning, It's irrelevant what their diagnosis is. They can continue to drive.
Okay. Right.
When it comes to other sorts of neurological conditions like narcolepsy, there is guidance on they can simply be signposted to the DVLA guidance on narcolepsy, and the narcolepsy guidance is not straightforward. It again rests on the principles of do not drive if you're sleepy, and if you've got narcolepsy, declare it, and the DVLA will ask the narcolepsy doctor, the neurology consultant overseeing your care, for an assessment.
Yeah. Okay. Right. So the kind of, I guess for me, the take-home point there is that anyone we're referring who's saying they're sleepy, if their Epworth score is over 10, we should be telling them not to drive until they've been formally assessed in clinic. Yeah.
Correct. Yes.
Okay. Yeah. Yeah. I mean, that's can be quite a challenging thing, but yeah. Good to know, good to have that clear anyway. Thanks. So just as we finish up, you mentioned there about the Sleepful app and sleep hygiene, and maybe we can try and leave links to some of those in the podcast description. Are there any other kind of resources beyond that you would suggest that patients access in relation to sleep?
So I guess a lot of them become specialty specific. Condition specific is what I'm trying to say.
Yeah.
So for insomnia, certainly Sleepful is a good resource. There is a very brief sort of section created by my colleague Colin Espy, who many will know was the architect of the Sleepio app and is a professor of sleep medicine at Oxford. And he's published quite widely in insomnia. And he has put together the 5 principles of good sleep health, which is like a short report, but something that both patients and practitioners could do well to read. So I'm happy to post that in the chat box and for you to share it with your colleagues. And that talks about how patients should be valuing, protecting, and prioritizing sleep in their lives, and how that might lead to sort of, in general, a better quality of life. And then there are sort of other resources which are more condition specific. The Sleep Apnea Trust is a good one for people with sleep apnea. Hope to Sleep is another good website and resource for people who want to mainly discuss or looking for information about sleep apnea. And then there's one called the Sleep School, which again is quite handy, particularly for practitioners. And then there is Sleep Station itself as a website, has a very useful sort of section on how patients can understand their insomnia better, and sort of emphasizes the principles of sleep hygiene.
Okay. Great. Yeah. Well, I'm sure we can share some of the links to some of those resources in the podcast description. So yeah. Well, thank you, Ram. It's obviously been a pretty quick whistle-stop tour of sleep, but lots of really helpful kind of nuggets of information in there for us, and I'm sure that will be really helpful for myself and my colleagues in terms of how we assess patients with sleep problems in our clinics. So yeah, thank you very much for your time and your expertise. Yeah, it's much appreciated.
Thank you for calling me.